All right, let's jump right in. Today is all about building a visual guide to mental health nursing. My goal is to give you a really solid mental model that you can carry with you, especially when you're prepping for an exam. We're going to break down how to recognize key conditions and, more importantly, figure out the right way to respond. So, let's get started. So here's our game plan. We're going to start with the anxiety spectrum, then get into how that looks in things like trauma, OCD, and phobias. From there, we'll dive into mood disorders, and we'll wrap up with psychosis and personality patterns. Think of it as our roadmap for today's walkthrough. Okay, first up, the anxiety spectrum. It just makes sense to start here, right? Anxiety is a universal human experience. But to really get a handle on the clinical side of things, we've got to understand what's actually going on, what's happening in the brain and body when that everyday stress turns into something more. So let's get down to basics. What is anxiety really? Well, you can think of it as your body's built-in alarm system. It's totally normal and honestly pretty useful when you're facing stress. It's that deep sense of dread you feel when something feels threatening. And we're not just talking about physical danger. It can be a threat to who you are, to your identity. The trouble starts when that alarm gets stuck in the on position, just blaring away even when there's no real danger in sight. This is so important to visualize for your exams. Think about how a person's world literally shrinks as anxiety ramps up. At a mild level, they're actually more aware. Their perceptual field opens up. But then, hit moderate, and boom, tunnel vision kicks in. The world starts to narrow. By the time someone's in severe anxiety, they can only see scattered, random details. And at the panic level, rational thought is just gone. Understanding this step-by-step progression is absolutely crucial because it dictates everything we do next. And here's where our approach as nurses has to pivot completely. You see, when a client is in that mild to moderate zone, they can still think, they can still problem solve. So we're like coaches, right? We can help them figure things out, talk it through. But the second they cross into severe or panic territory, that's a whole new ballgame. Their ability to process information just shuts down. Our goal isn't teaching anymore, it's all about safety. We need to stay with them, keep things quiet and calm, and just be a grounding presence. Seriously, if there is one thing you burn into your brain about severe anxiety and panic, it's this. You stay with the client, always. Your physical presence is the most powerful tool you have. You literally become their anchor to reality when their world is spinning out of control. It communicates you're safe without you having to say a single word. This isn't just a good idea, it's a fundamental rule of safe practice. Okay, so now that we have a foundation for anxiety, let's look at what happens when that general, free-floating feeling gets, well, laser-focused. It's like anxiety finds a specific target, whether that's a past trauma, a nagging thought, or a terrifying object. When we're thinking about PTSD, breaking it down into these 4 symptom clusters makes it so much easier to grasp. So first, you have the re-experiencing piece, the flashbacks, the nightmares. Then you've got avoidance. The person will do anything to stay away from reminders of the trauma. Third is that constant on-edge feeling. We call it hyperarousal. They're jumpy, always scanning for danger. And fourth, their whole inner world changes. They might feel detached, guilty, or just plain numb. And this leads us to something huge in nursing practice: trauma-informed care. This is a total game changer. It's about completely shifting our perspective. We stop looking at a person and asking, "What's wrong with you?" Instead, we create a safe space and we ask, "What happened to you?" It seems like such a small change, but it changes everything about the therapeutic relationship. It builds trust instead of judgment. Okay, when it comes to phobias, there's a right way and a very, very wrong way to intervene. The right way? It's called desensitization. You introduce the feared thing slowly, gradually, in a controlled way, so the person can build up their confidence and coping skills. The absolute wrong way? Forcing them to confront their fear head-on. That's not therapy, it's just going to make the fear worse and completely shatter their trust in you. And this just hammers that point home. It's a hard and fast rule. You never, ever force a client into contact with their phobia. Our number one job is to create safety. Forcing someone to face their biggest fear does the exact opposite. It's harmful, full stop. All right, let's tackle OCD, because our interventions here can feel, well, a little backward at first. Your gut might tell you to stop the repetitive behavior, right? But you can't. You have to understand that the ritual, the compulsion, is the only thing that's bringing down the sky-high anxiety caused by the obsession. It's a coping mechanism. So if you just stop it, their anxiety will explode. The strategy is to allow the ritual for now, while you work alongside them to build new, healthier ways to cope. Okay, time to switch gears and talk about mood disorders. The easiest way to get your head around this is to picture a spectrum with two extreme opposite ends. On one pole, you have mania, super high energy, everything is fast and euphoric. And on the other, you have depression, incredibly low energy, everything feels heavy and slow. And this chart, this is pure gold for studying. It lays out that contrast perfectly. Just look down the list. Mood, euphoric versus depressed. Energy, limitless versus completely wiped out. Speech, talking a mile a minute versus barely speaking at all. Self-esteem, feeling like a king versus feeling worthless. Seeing them lined up like this really helps you lock in those two very different clinical pictures. So when you have a client in a manic state, what's your priority? It's all about safety and managing that incredible nonstop energy. This person is physically running on overdrive. They are burning thousands of calories and might not stop to eat or sleep, which is incredibly dangerous. That's why things like high-calorie finger foods are a go-to intervention. They can eat while they're moving. We also need to get them to rest, reduce the stimulation around them, and provide safe outlets for all that physical energy, all while setting clear, firm limits. Now let's flip over to the other side of that spectrum. You have a client with depression. They're feeling hopeless, worthless, and have no energy. What is the single most important, most serious risk you need to assess for? How do you do it? You ask point blank, no beating around the bush. Have you thought of hurting yourself? There is an old, dangerous myth that if you ask, you'll plant the idea in their head. That is absolutely false. What you're actually doing is opening a door, letting them know it's safe to talk about it. This isn't just a suggestion, it's the standard of care. All right, we're heading into our final section, and we're tackling some really complex stuff: psychosis and personality patterns. Look, we're not going to become experts in 5 minutes, but the goal here is to give you a solid, simple framework to help you make sense of these really altered ways of perceiving and behaving. Schizophrenia can feel really overwhelming to understand, but breaking it down into these 4 dimensions helps a ton. So you've got your positive symptoms. Now, positive doesn't mean good here. It means things that are added to reality, like hallucinations or delusions. Then you have negative symptoms, which are things that are taken away or lost, like motivation, joy, or even speech. Throw in the cognitive and mood symptoms, and you start to see a full picture of how this condition impacts every part of a person's life. Okay, let's nail down the difference between these two because it's a classic exam topic. A delusion is a thought, a false, fixed belief. A hallucination involves your senses. It's a false sensory perception. And because they're different, our response has to be different. With a delusion, you never argue. You can't win. Instead, you focus on the feeling the delusion is causing. With a hallucination, you acknowledge their reality. I understand you're seeing something, but you gently state your own, but I don't see it. And let's be crystal clear. When it comes to hallucinations, safety is everything. The absolute most dangerous kind is what we call a command hallucination. That's when a voice is telling the person to do something. You have to ask about this. Are the voices telling you to hurt yourself? Are they telling you to hurt someone else? This isn't just a routine question, it's an emergency assessment. You know, when you first look at the list of personality disorders, it can feel like a lot to memorize. The best trick is to just use this 3-cluster system to organize them in your head. You've got cluster A, which is the weird or eccentric group. Cluster B is the wild group, dramatic, emotional. And cluster C is the worried group, the anxious and fearful ones. It's just a simple mental filing cabinet to keep things straight. And you know what? That really brings us to the core of everything we've talked about today. Your job, at its heart, is to be a master of pattern recognition. Can you see the pattern of escalating anxiety? Can you recognize the pattern of mania versus depression? Once you nail the recognition part, choosing the right response becomes so much clearer. So I want to leave you with one final thought to take with you. It brings us back to that idea of trauma-informed care. In your very next interaction with the patient, what is one specific thing you can do or say that shifts the question from "what's wrong with you" to "what happened to you"? Just think about it. That tiny little shift in how you see someone can change absolutely everything.